So, good morning, everybody. I'm Wenlie, come from Nanjing. First, let me introduce my hospital to you. This is Jiangsu Province Hospital of Chinese medicine, located in Jiangsu Province, Nanjing City, in the middle of the east coast of China. It's a very beautiful. It's one of the first principal hospital of traditional Chinese medicine in China. It has been improved the diagnosis and treatment ability of serious and difficult disease through integration of traditional Chinese medicine and Western medicine, and continued to maintain his leading position and ranked first in traditional Chinese medicine system of China. So if you are interested in Chinese medicine, such as herb, acupuncture, massage, and so on, you can visit our hospital. Our department, this is the members of our department. It's about 35 people in here. Now I will introduce my case from the following 7 aspects. The general information of the case. The person is 52 years old male. He is one of my patients who was admitted to the hospital in April last year. He got married and he is a worker. The chief complaint of this patient is sleep disorder for 5 years, urinary urgency and irritation for 2 years, and working unsteady for 2 months. In 2015, about 5 years ago, the patient gradually developed a sleep disorder. He was difficult in falling asleep and easy to wake up, accompanied by apnea, snoring, and nightmare. His wife reported that he had violent behavior during sleep, such as shouting, grabbing, punching, kicking. Neither the patient or his wife was hurt. So he went to the hospital to see a doctor and was diagnosed with rapid eye movement sleep behavior disorder. Then he was treated with Corticospinal and continuous positive airway pressure. The symptoms of the sleep disorders was relieved. However, about 2 years ago, the patient gradually consistently feeling the need to pee, peeing more frequently, unable to empty the bladder properly. They also had erectile dysfunction. Syncope occurred once during this period. About 2 months before he admitted to the hospital, he had the problems with coordination and balance. He clumsy and unsteady when walking. The patient is healthy before and has no family history of hereditary disease or history of smoking, drinking, or drugs. The physical examination of the patient is the mental status is normal. The speech is fluid. The cranial nerve examination is normal, except there is a horizontal dystagmus. The strength is normal in all muscle groups. There is no loss of sensory. The deep tendon reflex was normal and symmetric. The sign of Parkinsonism and Hoffman is negative, but the Romberger test is positive. Gait was unsteady. He was unable to work with a tendon gait and had a tendency to deviate to the left on walking. We also do some examination for the patient to help the diagnosis. We did the blood pressure in supine and opposite position. The supine blood pressure is 125 to 275 mmHg, and when 3 minutes after standing, the blood pressure changed to 84 to 30 mmHg. The EMG is examination of atherossphincter and neurosphincter showed there is neural damage. We also did a blood ultrasound, shows that the residual urine volume was 225 milliliter. The imaging examinations of MRI scan shows that the point time and the cerebellum atrophy point time, it seems like that there is a point time called a cross bonsai hill in the brainstems. We also did the PET examination for this patient. It shows that there is decreased metabolism in basal ganglia and the pontine and the cerebellums. So we summarize the case characteristics of this patient. He is a middle-aged male, account onset, slowly progressing, no family history, autonomic nerve dysfunction, cerebellar ataxia, and there is brainstem and cerebellum atrophy and decreased metabolism. So we think about the location diagnosis of this patient is autonomic nerve and the cerebellum. The qualitative diagnosis is we think it is degeneration. So we give the problem diagnosis of this patient may have been the multiple system atrophy. For the treatment of this patient, actually we have no good way to for this. Just give him clozapine and CAPA for his sleep disorders, and duloxetine to relieve the ataxia. Midodrine was given to improve the orthostatic hypertension. The most serious symptoms of this patient is he is suffering seriously from the urinary irritation, but we gave him a lot of drugs such as prednisone and levodopa and so on. He responds poorly to these drugs. So, and last, we placed a catheter to relieve the symptoms. Next, let's talk about the multi-system atrophy. MSA is a predominantly sporadic anti-onset and fatal neurodegeneration disease of unknown etiology. It is characterized by autonomic failure, levodopa unresponsive Parkinsonism, cerebellar ataxia, and pyramidal signs in any combination. It was first coined in 1969. The overall prevalence of MSA is estimated at 4.6 cases per 100,000 people. This disease is more common in men than in women. The pathological index for the diagnosis of MSA is widespread and abundant alpha-synuclein positive glial cytoplastic inclusions. Other characteristic the pathological findings was loss of urine and proliferation of glial cells in the olivary nuclear pons, cerebellum, and substantia magri, and stratum. So the clinical feature of MSA include autonomic failure, Parkinsonism, cerebellar ataxia, and corticospinal disorders by varying severities. For the autonomic failure, it includes also hypertension. The standard of reduction of systolic blood pressure by at least 30 mmHg or diastolic blood pressure by at least 15 mmHg. It can be asymptomatic or symptomatic. Symptoms of OH result from hypoperfusion and thickening occur. Another system is genitourinary dysfunction. ED is often the earliest symptoms and affect watery or male patients. The second symptom is urinary symptoms. Urinary include urinary urgency and irritation, urinary or facial incontinence. For the Parkinsonisms may mainly include bradykinesia with rigidity, tremor, or postural immobility. The tremor is usually irregular and postural or action, often in cooperation maculus, but a classic pure rolling rest tremor is uncommon. The Parkinsonism can be asymmetric, postural instability, occur earlier and progresses more rapidly than in PD. Parkinsonism usually responds poorly to chronic levodopa therapy. The following shows the cerebral ataxia, include ataxia of gait or speech, cerebellar or oculomotor dysfunction, and limb ataxia. There may be grace is evoked nystagmus. For the corticospinal disorder, the Parkinsonism may be is positive with the hyperreflexia. There are also other factors showing the MSA, include sleep disorders such as IBD or OSAH, also inspiratory sign serve dysphonia, new or increased snoring, cold hands and feet, pathological life or crying, and posture or action tremors. According to the clinical symptoms, MSA was divided into three subtypes. That is MSAP, MSAC, and MSAA. Structural and function images can also be helpful to diagnosis of SMA. The relative characteristic imaging findings of MSA in MIA shows that atrophy of brainstem and cerebellum, enlargement of cisterns and false ventricles. There also maybe you can see the hot cross bone sign, just like a kind of bread. Another system is the symmetrical abundant size of palm arms, just so you can see and hear. And also there maybe have a feature sign of Puntman. So the diagnosis of MSA were also divided into three groups. The first one is definite MSA. That requires the neuropathological findings include widespread and abundant cerebral synuclein positive GCIS and neurodegenerative changes in striatomicro and olivopond cerebellar region. The criteria for proper MSA include it's a sporadic, progressive, adult onset disease characterized by autonomic failure and Parkinsonism or cerebral symptoms. They can in the combination of autonomic failure and Parkinsonism or the combination of autonomic failures and cerebral systems. So the next is the character for the possible MSA. Just the combinations of Parkinsonism or cerebellum systems and at least one feature suggesting autonomic dysfunction and at least one of additional features. This list, this table lists the additional features of possible MSA. Include possible MSAP and MSAC. In these criteria, functional imaging examination such as MRI and PET and PET was used to is helpful for the diagnosis of MSA, just as we mentioned that there is some atrophy or decreased metabolism in the puntime and the brainstem and the cerebellums. There are also some supporting features. In other words, is the red flags of MSA include head neck dystonia, disproportional anticolysis, bent spine, contrastation of hands or feet, In surprise signs, severe dysphonia or severe dysarthrias, new or increased snowing, cold hands and feet, and emotional incontinence, irregular or postural or action tremors. If the patient have the following systems, that means not supports the diagnosis of MSA. That include classic pure rolling rest tremor, clinical significant neuropathy, hallucinations not included by drugs, onset before age 30 or after age 75 years old. Family history, if he has the family history of ataxia or Parkinsonism, then will not support the diagnosis of SMA, and the dimension and white matter lesions that suggesting the multiple sclerosis. The MSA showed different with others disease, mainly include PSP, CBD, and PD. These three diseases are rare diseases which are difficult to define according to the symptoms and signs. They are characterized by Parkinson's syndrome and with other signs. MSA and PD have similar clinical manifestations, but there are few effective methods to decrease them. The diagnostic treatment of levodopa has a certain diagnosis volume. PT often has a good response, but MSA has no significant effect. Structure and functional imaging is helpful for the definite MSA and PSA. For PSP, atrophy is mainly located in the middle brain, just shown in this picture. From the sentinel venue of MIA, the middle brain looks like the beak of a hummingbird. This is a hummingbird. That means we call it the hummingbird sign. If you see it from the coronal venue of MII, middle brain looks like the head of Mickey Mouse. We called it the Mickey Mouse sign. This sign just show this may be diagnosis the PSP. But for the MSA, the atrophy is mainly located in the pontine and the cerebral punctures, and there is the hot cross brown sign. It can help in the if you see the hot cross signs, it can help in the diagnosis of the MSA. So the treatment to the MSA, unfortunately, there is no specific treatment for this disease. Mainly symptomatic treatment, include the treatment to Parkinsonism. Usually we use the same drugs such as levodopa, dopamine receptor agonist, and morphine oxygen inhibitors to treat to relieve the system of the Parkinsonism, but maybe not very effective for the MSA. Just for the cerebellar ataxia, there is no drug. Just we give some physical therapy. For the treatment of autonomic nerve dysfunction, we can use the medulla to control the orthostatic hypertension. Patient can wear high elastic pants or operate high salt diet or drink more water to increase the blood volume. For the urinary incontinence or retention, we can give them oxygen buttons or catheterization to help the patient to change their life. The prognosis of MSA due to the OH, syncope may occur repeatedly, leading to head and limb injuries and fractures. Due to the stem limbs and limited activities, they can't take care of themselves. The sleep apnea can lead to the sudden breathing stop or cardiac arrest. That may be threaten the life of the patient. The average survival time was 5 to 6 years. Another report may be 3 to 9 years. The research, there are some research reported that the more serious the damage to the autonomic nervous systems, the less the damage to the nigrostriatal systems, the worse the progresses of patient. So that's all what I share to you.
Thank you very much.